morning, good afternoon, and good evening to all speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for the first session of today is our honorable guest from Indonesia, Prof. Julius Judai. Prof. Julius is the head of the Department of Neurosurgery at Universitas Pelita Harapan. Dr. Julius was a member of Indonesian Medical Association, Indonesian Society of Neurosurgery Indonesia, National Brain Foundation, international member of AIS, and international member of CNS. He was a previous neuro-oncology and skull-base fellow at the Toronto Western Hospital, as well as neurovascular fellow at the Fujita University Hospital, Japan. His clinical interests are focused upon neurovascular surgery, skull-base surgery, and neuro-oncology. We are extremely honored to have him today at our webinars, and he will be talking about endoscopic pituitary surgery from starting the service until reaching out. The speaker for the second session of today is our honored guest from China, Prof. Hua Xiaochuan. Prof. Hua is the Director of Neurological Disease Center at the Cerebral Vascular Disease Department, Beijing Anjian Hospital, Capital Medical University, China. He is a leading neurointerventional therapist who performs over 800 neurointerventional surgeries per year. He is a member of Youth Committee of Neurointervention, a branch of the Chinese Stroke Association, and head of Brain Heart Comorbidity Laboratory of Capital Medical University. He was involved in the actual writing of Chinese guidelines for endovascular treatment of ischemic stroke 2023. He has been at the forefront of several trials like Angel Aspect, Angel TNK, Angel Act, and East trials. We are extremely honored to have him today at our webinars, and he will be talking about AIS thrombectomy in China and thrombectomy strategy for ICAS. The chair for the first session of today's webinar is our honored guest from the United Kingdom, Prof. Ramesh Nair. Prof. Ramesh Nair is the consultant skull-base and neurovascular neurosurgeon, head of skull-base and neurovascular surgery at the Charing Cross Hospital and St. Mary's Hospital, Imperial College Healthcare, NHS Trust, London. Prof. Ramesh is the executive editor of the Asian Journal of Neurosurgery and the associate editor of the British Journal of Neurosurgery. He's an invited faculty of the ACNS as well as the WFNS educational courses conducted worldwide. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today is our honorable faculty from Japan, Prof. Yoshimura. Prof. Yoshimura is the professor and chairman, Department of Neurosurgery, Hyogo College of Medicine, Hyogo, Japan. Prof. Yoshimura was a past president of the Japan Society of Neuroendovascular Therapy, Counselor of the Japanese Stroke Association, and past editor of the Journal of Neuroendovascular Therapy. He was the president of Mount Fuji Congress as well as the Japanese Neurosurgical Congress in the past. He is a noted researcher and author of famous trials like Rescue Japan Limit Trial. We are extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both speakers and chairs and audiences to this online platform of the ACNS webinars. Very warm welcome to our colleagues in China, and we are extremely thankful to Prof. Subin for broadcasting the webinar on the WeChat channel. Dr. Atik Islam from Bangladesh is my co-host for today. With that introduction, I would like to hand over this online podium to our first chair, Prof. Ramesh Nair. Thank you.
Okay, thank you, Sam, and thank you, Atik, for moderating this session. First of all, I would like to thank my mentor, Prof. Yoko Kato, and his team, including Iraja and others, doing this magnificent work for some time since the COVID, if I remember, and it's a fantastic job imparting knowledge to audience, especially younger neurosurgeons across the world. I don't know how the whole team does it, but hats off to them for doing such a wonderful work. And also, I'm very honored to be in this panel with excellent neurosurgeons and masters talking about their experience. And I'll be keen to listen to them and learn from their experience as well. And I know Prof. Julius July from before. Briefly, we met. But he's going to talk on endoscopic surgery, pituitary surgery, which, as you know, there is an evolution of pituitary surgery starting from standard headlight operations in the past with then progressing on to microsurgical operation. Some of us do remember those sort of operations a long time ago. Initially, I remember starting off with the sublabial approach and preparing the patient for almost a week with the mouth gargle and antibiotics and Then went on to microsurgical transseptal approach, where you create a flap between the nasal mucosa and the midline septum, and then go directly into the sphenoid sinus, and then use the instruments to separate it, and then go into with the microscope. That's limited. And once we started using endoscope, I think we have the opportunity to expand it, and we saw that the illumination is much better, the visibility is much better, even though it came as with a price of learning a curve and complications to it. And so it is something that it's very important to listen to the seniors and the masters in this technique to avoid those sort of complications, at least in the beginning, and then avoid burning your fingers with the complications. All of us have suffered complications related to the technique or the instrumentation and the nature of the pathology itself. So all of this comes into play when you start doing these approaches. Once you get more and more experience in this, then you expand your horizon to, which is what I believe Prof. Julius is going to talk about. So I personally very eager to hear from his experience as well, having started off these sort of procedures for a long time now. Thank you. And with that, I welcome Prof. Julius to present his talk. Thank you.
Thank you, Prof. Ramesh. First of all, I would like to say thank you to all the ACNS team, led by Professor Yoko Kato, also my mentor. I was there in 2003, learned from her and from the past Professor Kano as well, and learn from their guidance to us. Can I share some? And also thank you for Dr. Raja to arrange these invitations for me to be able to share all these our experience and all the challenge also from Indonesia side. I think as Professor Ramesh mentions about the pituitary surgery from in the past, long time ago, we have been through many kind of sublabial, transnasorinopseptal, and once we learn the endoscopic, I think today it's already become a routine approach for us. In our institution since early 2008, it's already become a routine approach for pituitary surgery. In our main hospital in Siloam, Lipo Karawaci, until January 2023, there were more than 800 cases. And in our institutions, the pituitary adenoma contribute around 10% of all intracranial neoplasms that require surgery. Other hospital groups, also we have hospital chains that I will mention and explain to you later on, that Indonesia is archipelago, have many islands, and we have Siloam group hospitals. Today it's 41, but not all serve for neurosurgery. We do try help the management from the hospital also to build the service in the remote places as well. So in total until now, there were over 1,000 cases that we have been done through pituitary, through endoscopy. Majority, in the beginning, majority was done through single nostril on the right side. So I myself as a main surgeon and do it myself. So just through the right nostril usually. And currently, since October 2023, I convert all the surgery to binostril technique with collaborations with ENT surgeons. I met a couple friends and colleagues from States, convinced me that I think it's good to collaborate with the ENT surgeons. For sure, in the beginning, it's difficult because everything comes with money, price. If we have multiple surgeons involved, and it means it's more expensive surgery in our places. So Siloam Group is a big hospital group. I think it's one of the largest private hospital group. We have 41 hospital covering almost 65% of the province. And currently also they develop few clinics in remote area like Papua as well. So this is a map of what we have currently in Siloam Group. Over this 41 hospital, we have 28 that can serve neurosurgery. So once in a while, I will fly over to help a colleague to build the service in the remote places as well. I think if we look at in the main hospital in Siloam Lipo Village, until January 2023, we have over 800 patients. Majority presents with visual field constrictions, very classic one. I think it's account for more than 85%. Some patients also presents with cavernous sinus syndromes, and also patients around 15% presents with headache before. Yeah. And small number of patients, around 1%, have multiple episodes of admissions to hospital due to the electrolyte imbalance. So I think in our place, when patients have multiple episodes of hyponatremia, we suggest them to look for the causes. And one of the causes is pituitary adenoma. And few cases, 14 cases, we done surgery for prolactinoma, 8 cases for Cushing disease, 18 patients for acromegaly, and some patients will have combinations of acromegaly and prolactinoma as well. So if you look at the cases just for the pituitary apoplexy, if we look carefully, and if we take careful history examinations, and a majority of them will have prior headache. It's very interesting for us to know that if we take careful anamnesis to the patients, there is a certain number of patients that have pituitary apoplexy, have a previous history of headache. And we have patients also with presents with cavernous sinus syndromes, usually involved with third or sixth nerve. And in our understanding, and it's through all the cases that we going through, size is not important, but the acute expansions of the lesions is more important to cause the symptoms. And also we have 2 cases presents also with infection. So whenever we have a patients with cavernous sinus syndrome symptoms, I think we need to look at the acute expansions. It means that probably there is a apoplexia or coincidence with infection as well. This is one of the case that presents with infections and also with the pituitary adenoma as well, that presents with cavernous sinus syndrome. This is another case that we presents with cavernous sinus syndromes. And also, if we can see that there is a mucosal infected down here, if we can look at the picture, it's look ugly. And when you put a contrast, we can differentiate between the mucosal infections and the tumor as well. And we do have a patients that presents with sudden blindness, for such as the case present in 26 hours after the onset of the sudden blindness, and then came fly over to our hospital from Medan, and then we done the MRI urgently, and then found the apoplexy, and then done the surgery. Few hours later, he can have light perceptions, and then few months he can breathe and drive. But if you look at the visual field exam, it never come back to the initial, I guess, because of the sudden expansions and then causing injury to the second nerve, which is irreversible. And I would like to share, this is a 21 years old female, presents with prolactin levels, very obvious that this is prolactinoma, full dose on bromocriptine and then stop because of the intolerance. And then usually for the prolactinoma, if the lesions is very discrete and young female especially, we will suggest surgery instead of giving medications. Usually medications sometimes cause the lesions will be very hard to dissect as well. So for the prolactinoma, I think one of the indications when we find the lesions like this small, I think, and there is a high chance for the patients to get cured without the medications. This is done with the ENT surgeons. With this, we can do the by manual technique dissections in many said it's like a microsurgical technique to do the dissections. So it's very important to get everything out so we can provide cure for the patients. Just speed up the video. And we need to make sure all the tumor, sometimes it's very adherence because I think because of the previous medications that she get. So we can dissect and then see all the corner, make sure that we can dissect the tumor out. So for the collaborations with ENT, the beautiful thing is that whenever we have a CSF leak, because we are using the flap, we don't worry too much because the flap heal usually very fast, and then we don't need to put the lumbal drain at all. So gently doing the surgery. We can do the inspections at the end. So compared to the single nostril one that I done before, because one hand we holding the scope and the other hand we do the dissections, and as we can see that I don't think this is ideal things to do, but sometimes in the learning curve we know that it's probably not good to just pull, although it's very gentle. I think at that time I'm quite lucky that I don't cause any problems. So as you can see that we can slowly dissect and pull. But imagine that if we have by manual technique during dissections, it would be better for us to just dissect the tumor. So this is the difference between the single and binostril. Sometimes we have a patients like this with big prolactinoma, thousands level of the prolactin. And for this one, I don't think the surgery will cure her. So we just give medications and then it slowly shrink the tumor. And then at some points, we can offer some sort of radiations as well, like gamma knife at this stage, and then continue the medications. And with this big tumor, sometimes it's also shrink and then cause the CSF leak. So when they have a CSF leak, then we have to go in and then do the nasoseptal flap together with these ENT surgeons. This is when we done the, this is when the CSF leak happened, and then we do the nasoseptal flap to help. And then we also have a few cases with Cushing disease, as we can see here. Very obvious with buffalo ham, wrong fat pad dispositions, hirsutisms, moon facies, and it's very important to investigate and prove that this is a Cushing disease. And then once we prove this is a Cushing disease, and then we can look for the MRI, and very often we can see a small little nodule like this with non-contrast enhanced, and then this is the aim of the surgery, just to remove this part of the tumor. And once we remove it, and the next day we can see that the cortisol can jump down to very low. Sometimes we even have a withdrawal effect from the patient, so we have to substitute it with the oral cortisol or injections. We do have a case like a young gentleman with a cortisol level over 93 when we done the surgery, and then he got all these withdrawal symptoms with muscle ache and confusions and things. So we have to give cortisol injections for and tapering slowly for a few weeks. And we also do have a few cases with acromegaly. Yeah, as we can see, symptom is very classic. We can see that the skeletal overgrowth, we can see the frontal boosting, the jaw is big, and often that they complain about the size of the shoes is increased every period. They also have hypertensions, peripheral nerve entrapment, headache, arthropathy, and also glucose intolerance. It's very important to deal with this problem. Otherwise, they will have heart failure if we come too late. As you can see that this is a patient with acromegaly. If you look at the imaging variations, there is a lot of variations. If you can take a look, they can present like this picture. They also can present look like cysts. They can present look like meningioma. They also can present with cyst extensions to the lateral side, to intracranial, to the temporal side as well. So it's very important to look at the picture and understand them. For the fluid levels, imagines that patients lying flat, and then we can see the fluid level. This is a very classic sign for the apoplexy. I like to see the T2 because I think T2 provide a lot of informations for me, at least. If you look at the T2 for such picture, a lot of small little cyst degenerations like this one. I think this tumor will be very soft and quite easy to remove. So it's good for us to be able to tell which kind of tumor is tough in the beginning, so we can put a mindset before we going in, and then we know that how difficult, and also for the time estimations in the OR. If you look at the picture like this, it could be very fibrous. We can see the fibers like this. and then we know that we need more times during surgery. It might be good for us. So how do we get this all informations? I think we learn it from case by case. After surgery, we take a look at again the picture, and then start to realize that all the informations actually we can get it from the MRI preoperatively. Sometimes they also can present with dural tail. The one that present with dural tail usually quite vascular because the angiogenesis things, but dural tail doesn't mean this is meningioma, so it can present with other tumor as well. So sometimes we can have the tumor also presents with vascular malformations like this one, and then we know that it's going to be very difficult to deal with, and then we have to prepare a lot of blood because of the nature of the tumor together with the vascular malformations as well. We do have patients that presents with other problems, so it means that the pituitary is asymptomatic. And also these patients presents with seizure, and then we can see that he got a glioma and also the acoustic and also the pituitary. So we deal with the problems. So we deal with the glioma because he presents with the seizure. So in the beginning of my career, I always do very simple positions like this, always prepare for the fat in case I need it. But honestly, it's very rare we need the fat graft. Very simple, using the 0 degree, 18 centimeter length, 4 millimeter diameter scope. And the instrument is very, very simple. Nose preparations, I never trim the hairs in the nostril and just put the adrenaline pledgets to shrink the concave. And then I start to coagulate at the leg of the superior near the, so this is middle turbinate, and I coagulate near here and until up there. It's very rare I need to look for the ostium. So it's kind of the landmark we can use when I do the single nostril. It's about 1 centimeter above the corner, and then just at the leg of the middle turbinate and until the superior turbinate. So you just coagulate and then put a drill going in, and then we find this opening. Usually I don't need to open too much for the classic one. Once we I think enough the opening, and then we start to open the dura and then start to curate the tumor. For the third hand, I use the silastic tube, 10 F size, and then they provide the keep continuous aspirations, so it helped me to clear the field. So this is a majority of the case that done by single nostril. So just show some video, so you can see that I coagulate, and then start the opening the dura. You can see that the silastic tubes help to clean the blood or water from the irrigations. And we start to do the curette. And sometimes we can put the suctions at the opening just to help suck. As we can see, once we see the diaphragm coming down, have to be gentle. But even if we do it very gently, sometimes the diaphragm is so thin, and then we cannot avoid the CSF leak, as we can see this. So as we can see that, yeah, you can see the CSF leak. So we have to clean up all the tumor and then let it leak. So we prepare the fat graft from the abdomen. So what I want to show with these single nostrils, even if we have done many of the cases, putting a fat graft, I think is still very challenging and headache, because the fat itself is very slippery, and then it takes a lot of time for us just to waste time to put a fat graft into it. And it helps if we put the fat together with the Surgi cells, just to put it and hold it. So you can imagine that we can spend like 30 minutes just to put the fat graft into it. I think once we have the CSF leak, I think we need to make sure that it's not continuing. So we need to put the fat graft in it. So this is with the Surgi-cel, if you can see that. So for the fat graft with Surgi-cel. Still not going on. And then finally, I have to put the fat graft with Surgi-cel in there, so it will stay. And then I put another fat on top of it, and then put a glue. So to put a fat on top of it. So the fat itself, I believe, is create fibrosis. So it will seal off the CSF leak. But currently, once we do with the nasoseptal flap, we don't need to put the fat graft anymore. If you look at the result with the single nostril one, the visual improvement is also quite satisfying. The length of stay, for sure, for the single nostril, they can stay very short in hospital, usually 1 or 2 days in hospital after surgery. If I look at the extent of resections, because we have the follow-up MRI, if you look after 6 months, the extent of resections show that it's much better. I think it's because of some changes in terms of degenerations or vascular changes inside. It also show, as we can see, that this is the tumor. This is after surgery. We can see we still leave something behind on the superior anterior part, but we keep following the patients. After 8 months, it's just gone. So this is before surgery. This is after surgery. In the beginning, at that time, I think it's a curiosity that brings us to do the post-op MRI within 48 hours just to see instead of doing the CT scan, but we are not doing it anymore. So we do the baseline at 3 months always. So this is 1 year after. What about the subtotal removal? We just follow them. I'm not too aggressive just to come back and remove everything. The cavernous sinus involvement, for the record, we have been trying to get the flow seal into Indonesia, even though for the bovine one, until today, it's still not happening. So still a lot of challenge in our place to do extensive surgery. I do have complications. I have one carotid injury. So this is the beginning of my career, case number 5. So you can see that I just want to share what I have learned from this case. So you can see that this is the MRI. The patient presents with pan-hypopituitary. Then I do it with endoscopic. And the things that happen at close to the end, after I remove majority of the tumor, is that I try to grasp the small little bit of the tumor at the end, and then it caused disaster. I think I grabbed the wall, piece of the wall of the carotid artery. As you can see, at that time in 2008, we don't have colleagues that do endovascular, so we have to call the cardiologist to help us to put a stent. So she managed to put 2 stents and then help the patients. And then how I can manage the leak, the bleed. At that time, I don't have any experience with the carotid injury, and it was the beginning of my career with the endoscope. I just come up with the idea to use the Foley catheter. So this is the pediatric Foley catheter, the smallest one with the balloons. At that time, it's so panic, and then I forgot just inflate the air. Instead of that, I should put saline instead of the air. So it saved the patients, and then this patient still alive till today. I think I learned from the mistake because I grasp something and do the surgery without clear visions. So if we read the book, if you have a carotid injury, there is a salvage and rescue. So we can use cotonoid gel form. They mentions about fat. They mentions about muscles. And also, if the leak is big, they may end up with sacrifice the vessel to stop the bleed. We also have learned that patients can get a stroke and things. So it's very good for us just to be aware and then try to avoid it for any cost. We do have another complications like post-op hematoma. I think it's because of the dry nose, delay epistaxis. Sorry, the post-op hematoma, I think is due to the reduced surgery. We do have 2 at least that because of the fat graft before. So when we redo the surgery, the fat is very sometimes can cause trouble because of the fibrosis itself. So delay epistaxis, I think, is because of the dry nose. One case with late anticellular syndrome. This is interesting. Big tumor before, and then 6 months presents with getting worse visions at 6 months. In the beginning, it get better. As we can see through the MRI, the chiasms, the optic nerve is kink at this age. So we managed to put something to avoid it coming down again. So in terms of olfactory functions, based on post-operative history taking, 74% still be able to smell, and average olfactory recovery is 6 weeks. Yeah. Second surgery, as we can see, we do have second surgery recurrence, and sometimes we need to suggest gamma knife as well. Through reaching out, sometimes we have to get a picture from other hospital like this, and then we take a look at the picture. They send it to us, and then we go with a set, surgical set, simple one, and then go there and do the surgery. So this is a by manual technique that we done at the site hospital. So you can see that nowadays we do by manual technique with nasoseptal flap preparations by the ENT surgeons. I think it's make our life much easier, and the surgical result is more satisfying. So this is, as we can see, that this tumor. Can do by manual technique. So you can dissect nicely, slowly. and then we can do the inspections, especially toward the corner, until we are happy that we can get everything out. So this kind of technique only can be done with two hands. I think it's very important for us just to realize that. We remove the dura that infiltrate by the tumor as well. So we can see both sides. We can see the medial wall of the cavernous sinus. Very often we can see the imprint of the carotid artery as well. So just get everything out. We do publish a paper that mentions about the mononostril and binostril comparisons. I think nowadays I have to admit that doing single nostrils, yes, we do have a shorter hospital stay, 1 to 2 days. Binostril, they will stay longer because of the nasal packing. It takes at least 3-4 days for the ENT surgeons to remove the pack. And patients for the single nostril feel more comfortable. Binostril patients feel less uncomfortable especially during the nasal packing. But the single nostril, we as a surgeon realized that it's a limited surgical maneuver. So there is a higher chance for us to have a residual tumor, especially for the fibrous ones. And for binostril, I think it's more complete tumor removal. I at least more convinced myself. So this is our small team, ENT surgeons that committed to do the transphenoid together with the nurse that committed to develop it. I hope that in the future the team will grow bigger. Thank you.
Thank you. Thank you for this wonderful talk. You do have a very high number of cases. That is a valuable experience to listen to your talk and the nuances of the endoscopic approach. I have noted a few points, and I would like to go through those points I noted down, if you do not mind. I see that in young patients with very discrete prolactin secreting tumors, you advise surgery, which I think is the right thing to do. And I also recommend in many of our patients in UK, when there is a concern about some side effects of the medication, some patients may get mental problems if they have a background history of mental problems or some addiction problems. And some of this medication can give you gambling addiction as well. So we do tend to recommend surgery, which will avoid long-term medication. And also it's important in some patients where you cannot have a good rapport and a strong follow-up, because if you lose them and if you don't take them, they're not compliant with the medication, they will have come back in years later with massive tumors and much invasive tumors. So I think that's a very good point. You mentioned that. The another thing which I thought of, I saw that in one of these operative videos, you don't tend to strip all the mucosa, which I try to do as well, not to remove all the mucosa. Unless you're planning to use a flap, I would try to preserve the mucosa and open the mucosa only around the sella, so that you don't have to and it's so much cleaner as well. And I remember Sebastian Froelich here, who was talking about this his way of approaching these tumors. He likened those sort of situation with, if you're peeling the mucosa, it's like peeling the skin off a person. So it is just almost the skin of the sinus. So I think it is a good point. One case which I found very interesting when you were pulling, there was a leak, like a jet of CSF coming from the arachnoid. One eventually may need to repair with the fat graft or fasciolata or whatever techniques one may use. But one thing which I have found is that when you have a very pinpoint hole with a very precise bipolar ring, you could sometimes can just occlude that hole, and that should be enough. So I have some cases which I didn't have to do a lot of repair with the ongoing leak, because I could bipolar those tiny leaks with very gentle bipolar ring. And also I saw that you use sort of elastic tube to clean the end of the endoscope. That is good. And also there are commercially available endoscrubs which we find useful, because it comes with a system where you can irrigate the tip of the lens. Length of stay, I also find very impressive, that 1 to 2 days. I think that is the absolute sort of days they need to stay in hospital for most of our surgical concern. But often the endocrinologists who look after these patients post-op would want them to stay in for a final cortisol check and make sure that they don't. So many of them, our patients, stay at least for 4 or 5 days, unless they have some other plan to come back for a blood test. And bigger tumors, I find that if you remove bigger pituitary tumor, they have a tendency to develop either kind of a delayed hyponatremia, and then end up coming back to the A&E with worsening symptoms and headache and other complications, having to get admitted for treatment of hyponatremia. So that's my sort of experience with the bigger tumors. And I also, at the end, I would like to ask you about the residual tumors, how you would manage if you find that there is maybe not substantial, but at least maybe 1/3 of tumor remaining in a post-op scan. Then whether you would wait and see the dome to collapse, or whether you would go back fairly straight away in the same admission to repair it. But I see that you don't do MRI scans anymore, date in 3 months' time. So that is our experience as well. If you have a dome still persisting and with a good decompression inside, eventually they all collapse down into the cavity, and you don't have to worry about the chiasmal compromise. And then if the remnant tumor grows back, you can always treat them. Carotid injury, it's a feared complication. And previously we were doing all these scans mainly for extended endonasal approaches, but in our unit, we make it a protocol to do all the navigation scans, including MR angiograms and the CT scan for bony anatomy for every endoscopic case. So the last 10 years' time, we have picked up 3 cases where they've identified tiny aneurysm projecting into the pituitary fossa. And that was quite helpful. I don't think we would have picked it up if we had not done a preoperative MR angiogram. And one case was a Cushing patient. The tumor was projecting into the Cushing, the aneurysm was pushing into the pituitary tumor. That made the management very complex. I don't want to go on, but thank you very much. And one thing in terms of uninostril versus binostril approach, uninostril approach, I think, is very elegant, and there's less nasal morbidity. Quality of the nasal quality is much better after the operation. But for bigger tumors, it may be a bit of a problem. And you may find that in some cases with the septal deviation, one of the nostrils is bigger than the other, and you can always use a uninasal approach in that case, unless one is planning to do some septoplasty or some sort of septal nasal septal correction. And that is often done when you have an ENT colleague to help you. We have ENT colleagues helping all our cases. And it's quite good to have an ENT support, because one is to have the approach and septal flap. And also, secondly, when these patients come back with symptoms of crusting in their nasal cavity, it's good for them to be reviewed by an ENT surgeon, and so they can advise and maybe remove the crust and maybe further follow up. So with that, I will stop. And thank you again. For the talk. Wonderful.
Thank you.
Thanks so much, Prof. Ramesh. Okay, we have some questions. Dr. Atik would like to ask this question.
Yeah, thank you very much, Professor Julius, for your brilliant insight. Basically, I am trying to build up myself as an endoscopic scalpelist surgeon, and I am very much interested to learn about pituitary surgery and extended endoluminal approaches. And I am much more interested in functional pituitary surgery. I have an experience to do some Cushing disease cases in our country. My one thing I am asking to seek your opinion that in some of my cases, it was difficult to find out the lesion in MR scan. In two patients, we could do IPSS, and there was lateralization of IPSS sampling, and we searched for the tumor on their side. But in two cases, we failed to identify the tumor in MR scan or even IPSS. In those cases, we did exploratory surgery, and in one case we could succeed, and one case there was not good hormonal control. What we could do further in that case is cutting the stalk is an option for that case, or how could we manage that case? This is just seeking your opinion as you have the best experience in managing this type of cases. And second question is a simple question that in cases of growth hormone secreting macroadenoma, sometimes it is difficult to negotiate the telescope through the nostril. Sometimes we cut the middle turbinate, or sometimes we succeed to introduce the telescope by lateralizing the middle turbinate. What is your protocol? Do you lateralize the middle turbinate, or sometimes you cut the middle turbinate if necessary? Thank you very much.
Okay. Thank you, Dr. Atik. I think for the Cushing disease, I think the first thing we need to make sure that it is a Cushing disease. I think that's very important, because Cushing syndrome is totally different compared to Cushing disease. Cushing disease is always due to secreting adenoma in pituitary. We often use a dynamic MRI, and then we look at a very fine cut through the dynamic MRI, and sometimes we can follow the pattern of the blood that coming through the stalk to both sides. So I find it that we have sometimes distortions of that kind of because we can see the image is very beautiful when we do the scrolling of the dynamic, the blood, the contrast that coming down from the stalk to the gland, and every cut, and then we can see that, and the distortions maybe can give us an idea. And all in our cases, we don't have that much, but all in our cases, we can find the little nodule that non-contrast enhanced. So that's become the aim of the surgery. We don't have experience that we have to do the transverse sinus sampling, blood sampling for the ACTH until now. But in case we cannot find that's too small tumor, I think it's still useful to differentiate between left and right that we want to remove. And if you have done it both and it still doesn't really help, I think we need to come back to the initial state to review the case again, whether it's really a Cushing disease or the extra pituitary ACTH secretions tumor that presents with all the symptoms. You have the Cushing symptoms, syndromes, all the syndromes, but it might be some extra pituitary secreting ACTH. So for the second questions that you asked, now since we collaborate with the ENT, we always take out one concave middle turbinate on the right side, and then we do the flap on the right side. We have been trying and struggle with which is the best. We tried because Because before I decide that I want to go in and do more complex case like craniopharyngiomas, the stent, and also maybe meningioma in the future, I want to make sure that the surgical fields is clear for me before I decide to go in. I think the point is when we develop these things, patient's outcome and patient safety is always number one. I'm not confident yet. I'm not, although it's already thousands of cases we have done with single nostril. And when we do it with ENT surgeons, I think we have to put the rhythm together between I and the ENT surgeons to develop. So when I open inside, and then I can really make sure that no blood from outside going in, and then we can do really microsurgical dissections inside with the instruments. So, but for the first more than 800 cases that I have done from single nostril, majority I just push the middle to one side. So I always coming from the right side, no matter what. If I have the deviations of the septums, I can deal with the septum in the beginnings. I can do something and push it away. So I have my own idea. If I coming through the same orientations every time, I have a less chance to disorient it. So that's my principle. So I will always coming from the right majority of the case, and it helped me to less disoriented, because we don't always have navigations. Sometimes I have to travel to the remote islands, and then I can only rely on anatomic orientations. That's it. Thank you.
Thank you very much.
All right, we have a question from the audience. So the question goes like this: in patients of acromegaly tumor that engulfs the carotid, the tumors actually go lateral to the carotid. How do you manage these tumors?
Thank you. I think if we have a surgical skill good enough, nowadays we actually can peel off the membranes, the dura actually that cover the carotid, and then start to remove the tumor gently. But if we don't have that surgical skill, I think one of the things that we can do is put the gamma knife for the residual tumor. So we remove the tumor as much as we can, and then the residual tumor might be we try to put gamma knife. Besides, we can give injections for the octeotrip injections every 28 days, just to reduce the IGF-1. I think for the acromegaly, we need to realize that very often clinicians, we rely on the GH secretions, GH level. It's not always reliable, because GH secretion is always pulsating. So sometimes you can have low GH, but it's actually still acromegaly. So we have to rely on the IGF-1.
Okay, great. May I ask just a question myself? You've done so many surgeries, fantastic surgeries I've seen just now. How do we know that we have removed enough? You know, sometimes the pituitary tissue and the tumor is very hard to differentiate between it. And sometimes we try to be heroes, and we don't want any residuals, especially for acromegaly patients. How do you decide in your practice when to stop? Because sometimes you overdo it, you can get carotid injuries. You can even puncture the diaphragm muscle and cause a CSF leak, which actually can lead to disasters later on. So in your practice, how do you decide? Thanks.
Yeah, I think it's a very good questions. And even after many surgery, we still as a neurosurgeon, sometimes I still always ask, should we go more or should we just stop? So one of the things that I realize, yeah, it has to be individual for us. If at some point I'm have a doubtful decisions, I means that I might be very uncertain, so I will just stop. So that's one of the things. We can look at the membrane. Sometimes the tumor will develop the pseudomembrane itself, so we can dissect the membrane from the gland itself. But sometimes it's very difficult to find it. So for the acromegaly, the content of the tumor usually is like more like soft, sometimes with whitish things, and then we just remove the content and then try to look for the pseudocapsules if we can find it. If we cannot find it at the lateral side, just stop.
Right. Thank you so much for the insightful thoughts. Prof. Ramesh, anything else to add before we proceed to our next lecture?
Yeah, I think I've heard the questions. The one point I would like to mention about Dr. Attic's question about the Cushing's disease patients without a definite target. It's a big problem. And often the target can be indeterminate, even though the MRI report or the radiologist may suggest there may be some abnormality. You never can be certain. There are many cases when we went in, we didn't find tumor. So it is not an unusual scenario to have this sort of. So as Prof. Julius mentioned, is to the best thing is to study the MRI carefully and dedicate a pituitary MRI scan to look at. And also, for all our cases, all the Cushing patients get a standard workup, including the IPSS. But lateralization of the sinus or sampling is not definite for the side of the tumor, because even if you see one side ACTH more than the other side, that is not a way to tell that you cannot be never certain that the tumor is going to be on that side, because it depends on the venous dominance of the inferior pituitary sinus and the cavernous sinus drainage. So in certain cases, when we have a doubt about the tumor, we don't see anything at all on the scan. We have with Cambridge, we have been doing an additional radionuclear scan called a methionine PET-CT scan, which we've been validating for a number of years now, and we use it for these sort of cases. And there are some cases which are recurrent tumors after the first operation, when you don't know which side of the gland the tumor is. It may be very difficult to find out. So acromegaly, prolactinomas, and Cushing's tumors, we trying to validate it. Yeah, I think the second question was about your when to stop. As Prof. Julius said, it's all about experience, and you get that kind of feeling when to stop. It's a kind of judgment call. At some point in surgery, you know that going further, the risks are multiplying after a certain stage. So you need to make a judgment call when to stop it. And also, in order to avoid damage to pituitary gland, you have to have that experience knowing the tumor consistency versus the pituitary gland consistency, and the color and the appearance of the gland is separate. Coming to the lateral side, when the tumor is small or medium, sort of attached to the medial cavernous sinus membrane, for functioning tumors, we would try and remove that membrane. But in more invasive cavernous sinus tumors, I tend to follow the tumor into the cavernous sinus so that you will follow the path of the tumor. And tumor can be more superior or inferior or into the siphon corner. So you can follow this, but try not to go under the tumor and lateral to the tumor all the way to the superior component of the tumor, because there will be the nerves between those sort of septations. So try not to cut those septations. And in those cases where you want to resect more, it's a good idea to have neuromonitoring to look at the cranial nerves. So that you can have an idea where the cranial nerves are going to be in the cavernous sinus. But obviously, this is not for the initial beginner. So in cases where you don't think it is safe to go ahead, I probably would say that to stop at that point and consider adjunctive treatment for such cases. But when you get more and more experience, one would try more and more more invasive operations, including going into the cavernous sinus.
Okay, great. Thank you very much.
Okay. Thank you.
Yeah, so for our next lecture, let's invite Prof. Yoshimura to introduce our next speaker of Prof. Ho.
Hi, hello everyone. I am Dr. Yoshimura from Japan. I'm a chairperson of this session. I'd like to welcome speaker, Professor Flo Xiaochuan from China. Today he's going to talk about AIS thrombectomy in China and thrombectomy strategy for AIS. So please start your lecture, Professor Flo.
Okay, thank you. Thank you very much for the invitation, and I'm very happy to share these slides with you. And my topic is the acute ischemic stroke thrombectomy in China and thrombectomy strategies for AIS. And I'm from Beijing, China, and Beijing Anzhen Hospital. And here we could see Chinese Stroke Association has declared of next generation of perfusion therapy of China. And in the year 2020, the National Health Commission of Therapy of Acute Ischemic Stroke, the goal of national healthcare quality and safety improvement. Previously, I think China's stroke treatment has improved the eligible patients and therapy substantial room for improvement. The goal of the next generation perfusion therapy in China will be that by the above level medical institutions capable of treating cerebrovascular disease should offer intravenous thrombolysis and rising the proportion of Chinese patients who had ischemic stroke receiving intravenous thrombolysis to 80%, and the rate of endovascular therapy to 30%. So my content was introduction of the acute ischemic stroke thrombectomy in China, the progress and the number and the training program of this technique. And the other is because the AIS is very popular in Asian population and in China. So the thrombectomy strategy for AIS is quite different, and I will show the strategy in China and show some cases. First, please allow me to have an introduction of this regional quality control committee survey data. And during this survey data, the number of thrombectomy in China increased year by year. In the year 2015, after the guideline changed, we have positive results from RCTs. So in these years, the Chinese population had about 3,000 cases of thrombectomy 1 year, because no two centers. But after time, this number changed year after year. About every 2 years, this number doubled. And for the last year, there are about thrombectomy in Chinese population, and this number still increasing year after year, especially the price of techniques, price of devices, of total price of just expense of thrombectomy will decrease in the future year. This number will still increase because from patients are in sort of money to pay, so they refuse thrombectomy in China. And for the thrombectomy volume per 100,000 population, this number increased year by year, and for the last year, 2024, this number reached 6.25, and for the number of thrombectomy centers, this is very important. Very large centers emerged in China, and in the year 2015, I think not too much center could do thrombectomy, but last year this number increased to 1,427. This is a large number, especially for some very well developed province. They have a lot of centers could do thrombectomy, and for the Chinese government, they hope to have thrombectomy centers every 30 minutes distance. Epidemics could this allows the emergency to transfer patients within the 30 minutes distance, and for the number of thrombectomy centers per 10 million people, this number increased to 10.12 for last year, and also there are many large centers could do this technique and have a very good working flow, and have very cooperation with the emergency. So they have more patient shots, and the local centers that could not do thrombectomy will transfer the patients to their centers, and these high volume centers increased. For last year, this number reached 268, and there are a lot of very large centers, and some centers could do 400 and even 600 thrombectomies 1 year. This was super large, and some centers, even though they don't have too many chronic disease for neurointervention, but they have the chance to do thrombectomy, have enough beds to do thrombectomy. They attract the patients to come here, and with the experience increased, this number increased year after year. And the next is when for some large centers emerge, and these centers have the ability to do some clinical trials. Previously, there are some trials in China, for example, the East trial. This trial started to design in the year 2013, and in the year 2014, started enrollment, but trial to test whether thrombectomy is positive for anterior circulation. But during that year, the China center don't have too much high volume, so they couldn't afford to do RC study. So this trial changed to registry study, and registered some cases and published some data. And for this data, they showed in Chinese population, they have more ACNS cases, and they have very different strategies to do this kind of cases. And after that, another trial came into China, that is the Angel registry. This registry, because we have more ACNS patients, so how to do the antiplatelet strategy is very challenging. And this this registry study tells us that in China, they could use some drugs like taurophebam is safe and very suitable to treat patients when they have acute angioplasty or emergency stenting during the process. And also, this trials tell us the total cost of endovascular treatment for emergency patients increased year after year, especially in the year 2018. With the development of new devices, we could use the combined technique. The digital access caster and also the blue guiding caster are available in China. So this number of the cost increased year after year. And when we have enough patients to fulfill the RT status. There are many high volume and qualified centers could do the trials. So in China, they started the first trial, direct MT, and published in New England Journal of Medicine. And also in my team, we do angio serious studies. First is the angio registry, angio act registry, to test whether the working flow is enough and suitable to perform the RCT studies. And after that, we try to design some trials that could change the guidelines. So Endoscopic trials started and published in New England Journal of Medicine in China, and also the angio-reboot trials started. This is to test the rescue thrombectomy, used stenting or angioplasty, compare with continuous thrombectomy, which is better for patients, and this is also accepted by the lesson neurology. And another trial has just finished angio TNK to test the intraartery teneplace for the better result of patients after thrombectomy is successful perfusion. And another trial is still ongoing. So after we have enough cases and have the ability to do more high quality trials, the thrombectomy number in China increased year after year. Here is the Endoscopic trials. This is the first trial our team published in England Journal of Medicine, and to compare whether to treat or not for large infarct patients. And another is why in China the number of thrombectomy increased year after year. That is because the training system and the education system is very powerful. We could easily get trained for the doctors, and they like to study and have this pressure if they don't start to do thrombectomy because the guideline changed. Some patients ask for these techniques, and also the government side, they have to report the number, and this number is scored, and the centers will have a rank list of the rank, which is the first, which is the last, and qualified whether they are suitable as a comprehensive center. So the training started in the year 2015. There is a national training tour of stroke treatment key technique. This technique is mainly focusing on endovascular treatment, that is the thrombectomy. And in every province, all the doctors like to do thrombectomy will get together to promote this technique. Some very key techniques will be taught during 2 days education. And also, in the year 2016, the International Academy for Stroke Interventions of Chinese Stroke Association established. And for this International Academy, we do some training of neurointervention. And the first and the most popular classes is the thrombectomy. And during this training, we have the International Academy and also the cooperation group with WeChat and national tour, and also some aliens to cooperate to promote these techniques. And for the training and education of thrombectomy in China, we have standardized contexts for training course, the textbooks, and also the theoretical courses last for 2 days. During these 2 days training, all the doctors will come here to learn some basic ideas, how to evaluate the imaging evaluation, and how to choose and how to do the selective anesthesia, and also the class discussion. During the discussion, they will change ideas with each other. For some difficult cases, they will share the case and discuss together. And also for some doctors don't have experience, they will do the simulator practice how to deliver stent retriever, and also they will do some animal experiment to make them practice to pull out the stent aspiration and some combined techniques. And also, if they want to learn how the high volume centers do thrombectomy, they'll come to the high volume centers for 2 weeks to see how they do the thrombectomy, how is the working flow works, and after they came back to their hospital, they could start some working flow change and do thrombectomy by themselves, because for the doctors, they have already have their experience and the techniques in neurointervention. Only they don't have some experience in thrombectomy. They could do some intracranial surgery, intracranial neurointervention. So to comprehensive, the thrombectomy techniques will be much more easier for them. And the teachers in Chinese Stroke Association will go to the centers to working as the supervisor to give them a suggestion. And for this course and training, graduated from this training and spread to each centers in China and started to do the thrombectomy. And also they could have some local training centers and to start the training by themselves to the local doctors who have the ability and the local patients have this have this kind of disease to suitable for the treatment. And here is the local centers to also do the training and the same class and the same training course for the graduation examination. They'll be tested and give video record and also report some cases they have the cases they have treated during the last year. This education system lasts for 1 year. During this whole year, after this whole year, they are certified and graduated to be a qualified thrombectomy center. And also we have some WeChat online webinar to promote the case discussion, to promote these techniques more easy to make some local centers to get this technique. And also for the mechanical thrombectomy care systems, because the guideline changes very fast in China. In the year 2015, the Chinese guideline have the first level and highest level suggestion for thrombectomy, and also the guideline changed when the world have very good RT studies, have the positive evidence to get the Chinese guideline level changed and give them guidance and also a kind of protection to promote the thrombectomy. And also the National Health Commission make the rising the rate of reproduction therapy as the first important thing. The government will support this work. So in China, many doctors started to do thrombectomy. Many centers are very care about the thrombectomy number. They have many ways to promote these techniques. First is to accelerate the evidence-based evaluation of new generation of thrombectomy drugs like tenecteplase and retinplase to promote their approval for treating ischemic stroke and update the guidelines for reperfusion therapy. Secondly is the activity of promote dissemination and training of thrombectomy techniques to encourage the development of integrated imaging evaluation systems and new thrombectomy devices and conduct evidence-based medical research on thrombectomy. And thirdly is that in some small area, some local area, to strengthen the construction of 1 hour stroke rescue circle. During this circle, must have one center, at least one center could do thrombectomy and could do the thrombolysis. And the stroke centers established a more effective and China-specific organized stroke medical care system. The first is the activity promoted and research and application of artificial intelligence and intelligent medical technologies to promote thrombectomy and encourage some basic translational and clinical research combining with the brain cell protection and reperfusion therapy. So in China, many trials to test the brain protection had started. And the sixth is the conduct of national registry and safety monitoring. With the number increased of thrombectomy, the quality is decreasing. So have a monitoring system to increase the quality control is very important when this techniques is for these techniques is spreading. And the seventh is to establish new training and demonstration centers for next generation of reperfusion therapy. Some high volume centers also have some online show to do how they do thrombectomy. And maybe for these high volume centers, every day they will do 3 or 4 thrombectomy. So with these high volume centers online show it's very easy for the local centers hospitals to learn how the working flow and how to do it. And they will very help them to promote this technique. And the eighth is to establish partnerships between medical institutions and non-profit organizations, continue to enhance public awareness and education. The public education from TikTok and WeChat make the public know the large vascular occlusion need thrombectomy. And when they come to the emergency room, they require thrombectomy by themselves, and this will give the centers pressure to make them available for thrombectomy this technique. And then the ninth is to advocate for clinical research related to reperfusion therapy. Clinical research could give us more evidence and also make more patients maybe suitable for thrombectomy and make them benefit from these techniques. And when we have this kind of techniques very easily available in China, we still face some difficulties when performing this technique. That is because the ACAS is very common in Chinese population. For the 5 positive study trials, RCT trials changed the guideline, but they don't include patients with intracranial carotid stenosis. And for Chinese population is quite different. This number is in a large population. So during the thrombectomy, the progression, these techniques still changed because previously we don't have enough materials to do thrombectomy with very effective way. But after that, we could see the BGC, the aspiration caster, and the standard retriever. A lot of different companies invented high quality and easily available and very cheap devices to the Chinese market and make them available. So in the last year, we could see we have about more than 25 kind of thrombectomy standard retrievers and more than 17 kind of aspiration casters and a lot of different kind of balloon casters are available. So the technique changed from basics like guiding plus standard retriever to distal caster plus standard retriever, and also some aspiration techniques Now we have some ICAD specific techniques and also use the blue guiding catheter to treat the thrombectomy. And for mechanical thrombectomy, we know standard retriever, aspiration, and the combined techniques is very popular. But there are still some techniques are very important for ICAS patients. That is the angioplasty. We could do stenting and also the blue angioplasty as the first choice. And for some cases with residual stenosis, we could also do angioplasty for them to avoid stenosis to avoid reocclusion. And during the registry of Android Act in China, we found for the anterior circulation, maybe more than 20% patients have ICAS. And for posterior circulation, this number reached about half of them have this kind of stenosis. And there is a famous saying, know your enemy and know yourself is very important. So why is ICAD occlusion very challenging? Because it's the majority cause of failed thrombectomy with higher reocclusion rate, with additional rescue therapy required, and spend more money and longer recanalization time, and the risk of unstable plaque and new embolization. Also, the hot standing or the hot plaque need the antiplatelet strategies, so it's very challenging. And the first thing to solve this problem is to identify ICAD. If you did know it is ICAD previously, maybe you can give a loaded antiplatelet to avoid the thrombus formation during the thrombectomy procedure. First is the pre-thrombectomy, and during thrombectomy, we could have some strategies to know whether it's ICAD or not. First, pre-operative differentiation of ICAD is from the historic characteristics. And if the patients have the characteristics of male or sex or cholesterol level or circulation, they might be the ICAD possibility. And also the clinical manifestations, the severity maybe suddenly the severity reached the highest point, that may be from the cardiac, and gradually or fluctuate and the progress of the disease, that may be the ICAD population. And for the preoperative imaging, the location of ICAD is a very good way to identify for the proximal side occlusion of the basilartery. Maybe more ICAD is seen in this area. And for the distal part, most of them are the embolization. And this is the truncal type occlusion. Most of them are plaque rupture and caused occlusion. But for the branching side occlusion, that is the embolism migrated to the distal part and clapped at the perforation side. And also we could identify the ICAD with the imaging. First, the DWI maybe small infection call, and the vertebral artery, the calcification in NCCT also will be a way to identify ICAS. And also during the intraoperative identification of ICAD is from the collateral. If during the angiography, we could see a very good collateral of the distal part. Maybe this is chronic stenosis and sudden occlusion, maybe it's ICAD. And also the Apollo's morphology and hemodynamics could tell us whether it's ICAD or not. The shape of the embolism also could tell us which is ICAD. And during the operation, if it is a soft embolism, it's easy to navigate and pass through. But if it is ICAD, maybe have some more resistance, cause us too hard to navigate the microcasters. And also here is a way to identify, we call it the microcaster first pass effect. We first use the micro wire, get the microcaster pass through the occlusion side, and then leave the micro wire distal and pull back the microcaster. If it is ICAD, most of the time there will be a space between the room and we do angiography. The distal side will be appeared. If it is embolism, when we pull back to the microcaster, it will be re-occluded again, but this part is still couldn't be seen. And here is the standard retriever stand unseated effect. That is to deliver the standard retriever and give angiography to see which branch will be seen. If the two branches could all of them could be seen, maybe it's ICAD. And if it is embolism, one branch could be seen, the other branch is occluded by the embolism. And here are many ways to identify the ICAD and how to treat ICAD. First, microthrombectomy plus antiplatelet, whether it's suitable. Here's one case we could see the male 49-year-old no obvious relief after thrombolysis therapy in another hospital. And these patients had a knee scar of 17. And during the hospitalization, we could see the CTA showed the occlusion of middle cerebral artery, and the CT perfusion showed the Tmax. The ischemic area is 175 milliliter, and the infarct volume is very small, only 7 milliliters, and with a large ischemic area. So thrombectomy is the first choice, and we performed the angiography first. We could see here is a very severe stenosis, and during the angiography, we could see the distal side, maybe there is some fluctuate the thrombus here. So we decided to deliver the standard retriever first. Is after the delivery of the standard retriever, we gave one form of the thrombectomy of the standard retriever. After that, we could see the stenosis disappeared. Here, the blood vessel is very smooth, no stenosis at all. Why this happened? We are very curious about that. And during the follow-up, this stenosis still not very obvious. Only we could see from the high-resolution MRI, we could see there are some atherosclerosis of the intima. And when we see the plaque we have pulled out, we found we have done endoscopic by standard retriever during the thrombectomy because this is acute intracranial atherosclerotic occlusion. We use the standard retriever to do the endoscopy, and also the stenosis was solved by this thrombectomy. And this is not very common because most of the hot plaque after you do thrombectomy, they couldn't be moved out, and only some of them the stenosis were left there. So for most time we need to have the antiplatelet treatment. This is a female 70 years old with right limb weakness for 11 hours and progressive. The knee score is 23, and the local hospital have MRI showed the basal artery occluded, total occlusion, and have the emergency treatment for these patients. And we delivered the standard retriever to the distal, doing one thrombectomy with the standard retriever, and we could see here is the very severe stenosis. But after one thrombectomy, the stenosis is not very obvious. So whether we do angioplasty or not, I think maybe if we do angioplasty, spend more money, we could leave it next time to see whether the patient recovered very well. Leave it to do it in the second phase. And after the patients come back to the ICU, she recovered very well and come out from coma. And 24 hours MRI follow-up, we could see here is very severe stenosis. But things changed, the symptoms are very aggravated. And during the progress, 36 hours MRI follow-up showed occlusion of the basal artery. And reperfusion treatment are suggested by doctors, but the patient's family member refused to do the retreatment again because they think the first time we do that, transferred from another hospital, but failed. If we do it again, maybe the result is no good. So a wise person learns from his mistake. A wise person learn from others' mistake. So this mistake I never will do that like that again. So for ICAD occlusion, if the ICAD is severe, I will do angioplasty. Even for sometimes there's no very heavy distal thrombus, I will first choose angioplasty as the first choice and give the antiplatelet. And for these patients, male 64 years old, on-site time is 4.5 hours, left limbs weakness, aphasia, the knee score is 16 with middle cerebral artery occlusion, and that score is okay, suitable for the recanalization. And in this series of patients, we started registry study with high resolution MRI. We could see clearly from the high resolution MRI. Here is the stenosis prior to the operation, and also from the MRI, we could see some old infarction, and this side definitely the ICAD. And during the operation, we gave him the angiography, and so the collateral is very well. So for this side, maybe it's only a stenosis, severe stenosis, the acute occlusion. So I gave the balloon dilation with a very small balloon, and we could see the recanalization is performed, but the blood flow not well after 10 minutes, and it re-occluded again. And after that, we give these patients another dilation with a little bit larger balloon and inject antiplatelet drugs to make this effect. And 10 minutes later, the blood flow, antigrade blood flow very well, and no restenosis after another 10 minutes. Post-procedure CT so showed here's very small infarctive volume and follow-up MRI. And also the MRI, and after 24 hours, we gave him an MRI follow-up. We could see the artery changed a lot after the balloon angioplasty. The normal vessels could be seen very clearly. And also the follow-up from CTA 4 days later, we could see here is the stenosis of the middle cerebral artery, but the blood flow is very cold, so we leave it not treated to the next to see whether the patients will have symptom during the during the drug management. And for aspiration, is that suitable for ICAD thrombectomy? We have tried many cases, and here is one case with the male 52 years old, vomiting and unconsciousness for 6.5 hours. the knee scar is very high. We could see from the CT perfusion, the posterior has very large ischemic area, and the infarct volume is about 14 milliliters. We could see from the CTA the continuous is not good of the basic artery, and during radiography we could see the occlusion of the vertebral basic artery from the first segment of the vertebra. I use a French catheter directly cross the stenosis to do the aspiration, and after that, the vessel are totally recognized, and we give only the balloon angioplasty. We could see the result is very good, and we lived it. The patients recovered very well after this angioplasty. And we could also do the angioplasty cross ACAD for the combined techniques. Combined techniques are very popular for thrombectomy, because it will be more effective and cause very less migration of the thrombus to some other important arteries. And for this case, we could see the very severe stenosis of the carotid artery, and the distal side have the thrombus. So how to pass through this stenosis to do the distal pass combined techniques? We use the balloon to dilation the stenosis and cross the stenosis with the intermediate catheter and to the distal part to perform the combined techniques to how we could see is the balloon assisted technique to help the intermediate catheter pass through and pull out the thrombus. Here is the final result. The stenosis is very well dilated after the balloon angioplasty. And also we could like to use rescue stenting for ICAD if the stenosis is very severe and couldn't be sustained by the single balloon angioplasty. Here is the one case. The male, 58 years old, with right limb weakness, aphasia, with one segment occlusion. We pass through and give one angioplasty. After angioplasty, we found that this set has thrombus. So we do one thrombectomy with a stent retriever, and after that, we just give the angioplasty with balloon again, and use some self-extension stent to do the stenting and make it more well opened even during a long time. And after that, we could see the CT perfusion is very well, even though here are some medium stenosis. And also another technique is commonly used, that is the balloon angioplasty with the distal protection of stent retriever. This kind of stent retriever with very thin proximal side, so could be navigated through 017 catheter, and also could be resolved with a balloon. So we could use balloon to do the dilation and cross the intermediate catheter to pass through the plaque to do the distal part thrombectomy, the combined technique, and also after put back the stent retriever, we do some aspiration to clear some clots, and then directly deliver the stent retriever to the place and do the stenting. This will save much more steps for the stenting. And the rescue stenting for ICAD is very common for this case, with dizzy for 11 hours, common for 4 hours. We could see from the NCCT here is a very severe calcification. This is mentioned that maybe this side have very severe stenosis. So the calcification is very important. You must be careful about that. And the posterior circulation, we could see a large area ischemic, the disappear of the basic artery, the proximal and in middle side of the basilar artery. And here is the whole process. We do one angiography. We could see it's very blunt. So maybe the ocular side is not the right side. So we tried again and pass through this side and delivered the standard retriever. But here is very severe stenosis. And if we pull back the standard retriever, cross the stenosis, the thrombus may be migrated and collapsed and embolized the distal vessels. So we didn't pull the standard retriever. We just navigated the intermediate catheter cross through the stenosis. Use the advanced techniques to do the distal aspiration plus standard retrieval thrombectomy, and then we could see very heavy distal thrombus. And after that, I delivered one stent retriever. Here, that would be much more easier because you have passed cross through the stenosis, and the patients follow up angio is very well. We could see the standard the stenting is very good. And so for how to manage acute ICAD occlusion, I think many steps could be used. First, we could do thrombectomy first to see the result, and if the stenosis is not very severe, only the plaque caused thrombus formation. We could also use the aspiration first to clean the distal thrombus, and also if there's no too much distal thrombus, we only the stenosis is very severe, we could do the balloon angioplasty, and if the stenosis again left very severe, we could use standard angioplasty to make the arteries, the form of the ICAD side very more better for long distance. So here is the working flow, and based on the clot burden, and we have different thrombectomy choices. After the thrombectomy, the ICAD choice could be make the canalization very simple and easy. We could use antiplatelet and balloon angioplasty and stent implantation to maintain the recanalization. And for ICAD suspicious, if the clot burden is large, proximal or distal side, we choose different kind of thrombectomy techniques. But if the residual stenosis could be seen, if it's moderate, we will give the GP2B3 inhibitor like terifibam. If it is heavy, we will use balloon plus angioplasty and also give the GP2B3 inhibitor. And if the blood, the clot burden is very small, we will do balloon angioplasty first, and to see whether the stenosis needs rescue stenting. And so much for my presentation for the Chinese stroke history and what is the strategy of thrombectomy of ICAD population. Thank you.
Thank you, Professor, for your wonderful lecture about the China AIS treatment and also ICAS occlusion. It was very interesting. Are there any questions or comment from the audience or panelists? So I'd like to make a presentation. So I'd like to know, are there any difference in thrombectomy technique in ICAS treatment or anterior or posterior circulation, because you show the bilateral occlusion and also MC occlusion. So are there any difference?
I think for ICAD and now in China we use the same technique. It calls the basis technique because this kind of stent retriever, we could navigate the balloon to use to the stent retriever to reseat it, and also by this balloon we could do angioplasty first and navigate the intermediate catheter or aspiration catheter cross the stenosis, and to do the combined technique aspiration and thrombectomy to the distal, and then we will navigate the standard retriever to distal again, and pull back the intermediate catheter to see the stenosis, whether it's severe or not. If it is not very severe, we will just leave it. If it is severe stenosis, we will do the stenting of this part. But before we do this, we will give antiplatelet, the tafribam, in the maybe before the thrombectomy. We just deliver the stent retriever, then we give the 2B3 inhibitor.
Thank you. Any other questions from the panelists or others?
Prof. Ho, may I just ask out of curiosity? I mean, there are still failures of thrombectomy, and success rate sometimes not that high. Do you all practice doing open embolectomy or bypass in these kind of situations in your site? Thanks.
In my site, there is no too much bypass practice because we only do neurointervention, no surgical treatment of the acute ischemic stroke. But in my center, we will, in China, many centers could do bypass techniques, but this is for chronic, some very chronic occlusion, and for moyamoya disease, they will do bypass and very popular in China. But for thrombectomy, it's not commonly used.
Okay, thanks.
And my next question is, you showed a very beautiful scheme how to treat AIS occlusion. Okay, in that your scheme, you divided into two groups based on clot burden, right? So my question is, how do we know the clot burden, large or small, before treatment? So what should we do?
Yeah, it's a very good question. Thank you. We commonly use the CTA, and the CTA original pictures. We could see the collateral of the distal, whether it reflow from this part to the proximal part. We could see from the CTA's original pictures to see the density of the distal part, the occlusion part, and to guess whether it have a very large burdens. But we could also like to use the technique is the first pass techniques. We use the microcatheter pass and leave the microwire there and pull back the microcatheter and give an angiography. If the clot burden is very small, the blood flow will be passed through the stenosis. If the clot burden of distal is very heavy, the clot will re-occlude the distal again. So maybe we will need to deliver the standard retriever. After deliver the standard retriever, we will give another angiography to see how the clot burden. If clot burden is very heavy, we will use the balloon to do angioplasty of the proximal stenosis and cross the distal catheter to do the combined technique of the distal clot. If for the basal artery, if very severe stenosis and very small clot burden, will not do thrombectomy. Maybe retrieve the standard retriever, and if the clot burden is small, we will not do thrombectomy. We just pull back just reseat it and do the directly to do the angioplasty plus the tafribam intravenous treatment.
It's interesting. So in that case, you navigate the stent retriever to the occlusion site when ICAS is suspicious, right? So in that case, which stent is good, best in your experience?
I think in China have some national made standard traverse that could navigate it from 017 microcatheter. So it's very simple and easy, and also could use the balloon, the intracranial balloon, to cross this standard traverse to do the angioplasty.
Oh, really?
So this is maybe is for the commonly used centers don't have this kind of function. Only this kind of standard traverse is especially made for ICAS to do this technique.
Okay, thank you. So thank you, Professor, for your wonderful lecture. Okay, we may
thank you.
We may close this session. Thank you, everyone.
Yeah. If there
Thank you
are
very much.
no further questions, let's close the session for tonight. On behalf of Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to thank both the speakers of today, Prof. Julius and Prof. Hoa Seo Chuan, as well as the chairs, Prof. Ramesh Nair and Prof. Shinichi Yoshimura, for the time and support for the ACNS webinar. Special thanks to Prof. Subin for broadcasting this webinar on the WeChat channel. Special thanks to my co-host as well, Dr. Atik Islam, for joining me today. So until we meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.